My name is Richard. I'm an assistant professor of infectious diseases here at Mount Sinai. I also am the associate program director of the Infectious Disease Fellowship. So I help teach the junior doctors as well. So we're going to be talking about monkeypox today, which is an illness I've seen a lot of here in New York City as part of the early epidemic. And I'm going to try and give you kind of the basic facts of what you need to know as people living here in the city. So just as part of any sort of presentation, just want to make sure you know if I have any conflicts of interest. I don't have any personal interest to disclose. I do receive grant funding from an award from the Bristol Myers Squibb Foundation. So not the pharmaceutical company, the foundation helps support researchers. So can I kind of give an overview of what I'm going to be talking about today? I'm going to start with some basic virology, just talking about what monkeypox is. Then I'll talk about some of the history of the outbreaks we've seen in infectious diseases. There's some concern that monkeypox is a new infection, but it's actually not a new infection. We've seen it several times before. Then talk about our current outbreak. Then talk a bit about what you might see clinically if someone contracted monkeypox, then treatment and prevention. So monkeypox is part of a genus of viruses we call orthopox. This is a microscopic picture of monkeypox here on the right. So that includes many viruses, some of them which are very mild, some of them which are very serious. Kind of that the most famous member of the orthopox family is smallpox, with the name of this, which is variola. And that is a highly infectious, deadly disease that was luckily eradicated by global public health cooperation in the 1980s. But there are other diseases in the family that are much less severe. So like cowpox, which is a disease that people who milk cows used to get in the 18 and 1900s on their hands, which would cause bumps on their hands, is also an orthopox, but a very mild illness. And then vaccinated, which is another mild orthopox, is what the actual monkeypox vaccine is made out of. So just to say that there's a wide variety of viruses in this family, some very deadly, some very mild. So just because it's an orthopox doesn't mean that it's deadly. But they all kind of have similar symptoms. So all the orthopox viruses all cause fevers, kind of cause malaise, which is the technical term for like feeling achy, not generally unwell, as well as skin lesions of some sort, some sort of bump or pox. That's what the family is named after, pox is. So in infectious disease, we talk about the animal reservoir, but where does the virus live when it's not infecting people? And for monkeypox, we just don't know where the virus lives when it's not infecting people. Monkeys have very little to do with monkeypox. They're not a natural reservoir of it. They're not a method of transmission. It's just kind of a misnomer, but we don't know what animal lives out there in the world. So that's going to be an important thing to figure out as we figure out if it's something we have to worry about for the future. This illness was first described in 1958, so this is not a new virus. We have known about this since 1958, so just to say we've seen this before. And that was described by some scientists in Denmark. And the first human infection was described in 1970, and that was in the Democratic Republic of Congo. And ongoing, there have been monkeypox infections in continental Africa since then. This has been a virus that people living in Africa have been managing and dealing with for decades. Just to say again, this is not a new virus. It may be new to us here in America, but it is not a new virus. Here it is in pink. And just so some history of the outbreaks that we've seen of human infections of monkeypox. We have them going, there have been several in the last 20 years. Here in the US, in the United Kingdom, in Nigeria, in Zaire, in Singapore. Some of these were from exposure to animals, some of these were exposure to people. But just again to say, even the outbreak that we're having now is not a new thing. We have had monkeypox outbreaks in the past. So just to kind of give some reassurance that we have been down this road before. So to talk about our current outbreak. So we actually had some pretty detailed information about how this all happened. So in April of this year, late April of this year, a British citizen was traveling in Nigeria, and at that time, this person began to experience monkeypox symptoms. This person returned to the UK in May of 2022, and then isolated to recover from their illness. And then about a week later, public health authorities in the UK, in collaboration with the World Health Organization, began doing contact tracing to look for people who may have been exposed to this person during travel and their time in the community in Africa as well as in the US, in the UK. And that is where this all came from. So just to say that infectious diseases, it doesn't necessarily take a major global event, it can just be a flight. And so since then, these are all the countries that have reported monkeypox cases in this current 2022 outbreak. And the bigger the circle is, the more cases that they've reported. So you can see here, the US has the largest circle of all the countries. This here is Spain, there have been some cases in Brazil, all over Western Europe, as far away as Australia, Russia. Just to say that this virus has traveled quite far and wide. And to distinguish that from the blue cases, well, these are endemic cases. As I mentioned before, monkeypox is an illness that affects people in Africa all the time. So these are cases that are endemic, not thought to be from this particular outbreak, but all these orange cases are all probably linked to this particular outbreak that we just described at the start of. So it's all over the world, as I mentioned, 50 countries. As of late August of this year, 50,000 cases. And just to reassure everyone, of all those 50,000 cases, there's been only one death. And that was someone in Africa who had a very severe illness. But regionally, the majority of cases actually been in Europe, because that was where the outbreak began. But now we've seen it in the Americas, meaning both North and South America, 2% in Africa, and that 2% is linked to this outbreak. And then some cases in the Mediterranean, as well as the Western Pacific, so Asia and the South Asia Sea. So just to say, this has moved all over the world, probably due to global travel. The world is getting a lot smaller, and so infectious diseases take advantage of that. So it's also all over the United States. So while cases may be concentrated in major cities like the U.S., like New York or San Francisco, but there have been cases reported in almost all 50 states. And in this map, the darker the color, the more cases that have been reported. So we see the majority of cases are in New York, Philadelphia, Pennsylvania, Texas, California, Florida, but there are cases all over the U.S. Again, just to say that this is not a local problem, this is a global problem. And we may have more cases here in New York than other places, but again, this is not just our problem, it's a world problem. And most cases have been described among gay and bisexual men. And monkeypox is not a sexually transmitted disease. I'll go into a little bit more into that further on about why it's in that community, but I do want to reiterate, monkeypox is not sexually transmitted. It is spread through intimate contact, and that can mean many different things. So this is looking at the age of people to get an idea of who may be at risk for contracting monkeypox. And we see the majority of cases are men, that's the dark blue. And they tend to be men in their 20s and 30s are the people who are at highest risk of contracting monkeypox so far, at least. There have been a smattering of women. Orange here is cisgendered women. But again, the majority of cases are in men. Just to get an idea of who's at risk of monkeypox in this current outbreak. And so this is looking at the kind of the racial and ethnic breakdown of cases. Initially, there was a majority of cases among white people. I think that's probably about access to testing and healthcare access in general earlier on in the epidemic. But we see now that it's been more evenly distributed between Black, Hispanic, and white patients, with no one particular group having a larger share of cases than other groups. So just to say, I think this is an infection that can affect anyone. So this is New York City. I think this is a very reassuring graph in my opinion. So this was as of Monday, of last Monday, the 9th. And so the higher the graph here, the more cases have been diagnosed in a single week in New York City. And we can see that we had quite a spike upward, peaking like in late July. And then we've had a precipitous drop here now to September. So it looks like the number of new cases in New York City are decreasing. We have to be careful being reassured by this, because this is just cases that have had positive test results. So maybe people are staying home. Who can say? But I would say this anecdotally, I've seen fewer cases recently compared to earlier on. So I do think that New York City is getting this under control. And that's probably due to a combination of things we'll talk about more later. So we'll talk about monkeypox clinically. So what does monkeypox do to the body? What might you see? So it takes about 7 days after exposure before someone might be experiencing symptoms. We call that incubation. So when someone is exposed to a virus, someone doesn't get sick immediately. It takes some time for that virus to invade parts of the body, set up shop, and start causing illness. Every virus is a little bit different. Some take a very long time. Diseases like HIV take a very long time. Other illnesses may appear very quickly. Like the common cold usually appears pretty quickly. Monkeypox is somewhere in the middle. It takes about 7 days. So some people have gotten ill as early as 3 days after likely infection. Some people as long as 20 days. So it's a pretty wide range. But most people about a week or so. The most common symptom of monkeypox is a skin lesion or a rash. The rash can take a couple different forms. We're going to show some pictures of those in a moment. So nothing not safe for work. I'll show some G-rated pictures, but it's an idea of what might look like on someone's skin. Second most common symptom is fever, then lymphadenopathy. So lymphadenopathy means swollen glands, and that could be anywhere in the body along the lymphatic system. So usually that's either at the base of the neck, in the armpits, or in the groin. And that's a sign of the immune system working. Monkeypox causes a powerful immune response, and that would be the body's fighting it off. So that's also a very common symptom. And then we get to less common symptoms based on this particular study, though anecdotally, people have many or all of these. Feeling fatigued or lethargic, headaches, muscle pains, that's what myalgias mean, or anal or rectal pain, which has been a lot more common with this current outbreak compared to previous outbreaks. So these are the different skin manifestations. So I also want to take a step back and just to say that on the news, they show pictures that might seem very, very scary, people covered in lesions, things like that. The majority of people with monkeypox do not experience that. They're kind of showing the most severe cases on the news. So even if you know a friend or someone you know says they had monkeypox, it does not mean that that will be their experience. There are kind of a few different types of rashes someone might get for monkeypox. And rashes are a little bit confusing because, everyone's skin's a little bit different. Things may look different on one person's skin than another person's skin. But some things that go along with monkeypox lesions are, these are the most common appearances. So the most common one is a vesicular papular rash. So what does that mean? A papula means a little raised bubble, so like you might see with chickenpox or something like that. And vesicular means it has fluid inside of it. That is the most common monkeypox rash. Then the next most common are ulcerated lesions. So this is like a hollowed out, like a scooped out lesion. And it could be one or a scattered group of them. And then macular lesions, which are lesions that are flat and have a dark circle in the middle. But again, it can take many different forms. But some things to help distinguish monkeypox lesions from other things like, bug bites, other skin rashes, things like that. The lesions are usually firm to the touch. So they're not squishy, they're firm, and they're often painful. So those might be a way of figuring out, should I see a doctor about this or not? Is this something I can just say, oh, it's a bug bite, or is it something else? If it's firm to the touch, if it doesn't look like your regular mosquito bite, if it's painful in a way that you haven't experienced before, that might be a call to give your doctor a call to get some advice about that. So most lesions are, in this current outbreak, are in the anal genital area. It doesn't necessarily mean that that's where somebody contracted it. And this is something we're trying to figure out with this current outbreak. It's different from other outbreaks. The lesions are concentrating in that part of the body. But people can also get it on their trunk, meaning their torso, their arms or legs, or on their face. It can really go anywhere on their body. It can just affect one part of the body, or it can be what we call disseminated, meaning it affects the entire body. So when it comes down to it, basically, there's no one rule for this infection. That's part of what makes it so challenging, because there's no one thing I can say, oh, absolutely, that's definitely this, or it's absolutely not that. It can take many different forms depending on the person. And so really what it boils down to is if you're ever worried, give your primary care doctor a call and they can help you figure out if you have to do testing or not. So there are some people who have very severe illness. So when we say severe illness, what do we mean by that? That could be having very bad pain. That could mean having what we call a super infection, which means that they have a monkeypox infection, they get a second infection on top of it, like a skin infection with a bacteria. Having severe pharyngitis or having a severe sore throat can be part of monkeypox. Having it involve the eye or around the eye can be a severe disease. Sometimes people have had some kidney problems. People have had myocarditis, so inflammation of their heart. And viruses in general can do that, and monkeypox, along with other viruses, can do this as well. Proctitis being a kind of internal anal pain. And then finally, anal stricture, meaning that after someone is healed from their monkeypox infection, their anal canal might get tighter and less flexible, and that can cause problems with having bowel movements.
Right in the middle. Okay.
So this is where I'll talk about what monkeypox looks like. So it kind of has a predictable progression.
I'm sorry to interrupt you.
Oh, sorry.
We're getting a little background.
I'm sorry.
And yeah, I'm not sure. I know for everybody, Richard is actually in an airport right now. So
want me to go over that last slide again? Was it too noisy?
I think if just going forward, again, it's if you can just speak louder and maybe just a little more slowly, that way we could just hear, even if there's background noise, that would be great.
Sure, of course.
Thank you.
I know I talk very fast. I'm a life.
No, that's okay. If there was no noise, it would be fine, but we just started getting some, so.
Okay, so monkeypox has a predictable progression of illness. The lesions will change with time. And so this is a case of a person who contracted monkeypox of exposure here. About 4 days later, he got a single genital lesion. Then about a week after, and then a week after that, he started feeling systemic symptoms. He started feeling fevers, chills, muscle aches, things like that. Then about another week after that, he had lesions in other parts of his body, including his face. And then about 2 weeks after that, the lesions started testing negative. And then finally, about a month after all this happened, the lesions were all testing negative for continued virus being present.
Okay.
So that's about the usual course of monkeypox. It takes about a month to recover from it. The skin lesions often precede the systemic symptoms in our current outbreak. It was flipped in earlier ones, but for our current 2022 outbreak, usually people get a skin reaction first and then feel sick a few days later. And then the skin lesions evolve in many ways. They'll change appearance. Eventually, they start filling with clear fluid. That fluid then becomes cloudy. Then the fluid will drain. Then an ulcer will form. And then the ulcer will fill in. And then the skin will heal. Someone is considered infectious until the skin is fully healed and there is no more scab or without lesions. So that's why it takes so long for someone to recover from monkeypox. They have to stay home and isolated until all the lesions have healed and new skin has formed. But that will happen given time. So to talk about how we treat monkeypox. So there is no current FDA-approved treatment for monkeypox. And most people have very mild disease and recover without any treatment. Most people will have some systemic symptoms like fevers or body aches. They'll have some skin lesions on their body. Then over a course of 2 to 3 weeks, the lesions will go through the progression I described, will heal, new skin will form, and they'll be back at their baseline without any lingering symptoms. That's most people. Some people, either because of bad luck, because of the location of those lesions. So say if they had a lesion appear in a part of their body they need to use every day. So if it was like lesions in their mouth that were painful and they couldn't eat, or lesions preventing them from passing urine or preventing them from passing stool, those folks may have a different experience, and those would be the folks you'd want to treat. Additionally, we would want to treat people who have other medical problems that may increase their risk of having a poor outcome with monkeypox. So that would include people who have immunological diseases, people who have cancer or on cancer treatment, people with uncontrolled HIV, and people who have skin diseases, so things like psoriasis, eczema, things like that. People who already have inflammatory skin diseases, their skin may be more prone to having a bad reaction to monkeypox compared to the average person. So those are the folks who would consider treatment in. But again, also to reassure you, if you have friends or family who may be exposed to monkeypox or may catch monkeypox, most people have mild disease and it gets better on its own without intervention. It's very much like chickenpox for most people. It's just in some people, either because of bad luck or because of their other medical problems, they have a more severe course. So we have 2 medicines that we can use for monkeypox. Because if we remember back in the beginning of the talk, I mentioned monkeypox is part of a family of viruses called orthopox viruses. And so we have medicines that treat orthopoxes in general that have been effective in treating monkeypox. We don't have FDA approval for that because up until 2 months ago, we didn't have many cases of monkeypox in America to test the drugs on. Now, hopefully, maybe we'll get some more information, be able to approve these, but we do have medicines available. I'll talk a little bit more about them in a moment. So the first medicine, this is probably the one you hear most about on the news. It's called tecovirimat, but the trade name is T-Pox. That's usually how it's referred to. It's an oral pill someone takes for 2 weeks. Because it is not FDA approved, it's not something your doctor can just write a prescription for you. There's a special process you have to go through to get it, where the CDC will dispense it, but you have to sign written consent saying you understand the risks and benefits of taking a medication that's not FDA approved. And the most common side, it's usually pretty well tolerated. Most of its side effects are kind of belly symptoms. People have things like nausea, vomiting, abdominal pain. Those are the most common symptoms. Rarely you might give it to someone through an IV if for some reason they're unable to eat. Let's say they're very, very ill and they can't eat and they can't take food in, or if they have such painful lesions in their throat they can't swallow, you might give it to someone through IV. And then you might also have kind of common IV symptoms, pain where the medicine's going in, redness, tenderness, things like that. And this medication specifically has to be taken with a high-fat meal to help absorption. So we ask people to have a high-calorie meal with all the pills they take. So something like a cheeseburger, a slice of cheesesteak, something substantial. So no one's on a diet when they're being treated for monkeypox. And this is the medication that we're using here mostly in the U.S. And the reason why that is because it has a relatively favorable side effect profile. So the side effects are usually pretty well tolerated and pretty rare. most people take the medication without any problems at all. And so just to kind of put it in perspective, most people don't need any medicine, and the ones who do need medicine, most people get this medicine, which is very easy to take. But your primary doctor can't prescribe it. You have to go through a special process for it. So the other medicines we have are a pair of medicines called brimcidofovir and cidofovir. We aren't using those here in the U.S. for routinely. Those are research. Those are primarily being used for research, and they have a less favorable side effect profile. So not really something that's being widely used right now. And then finally, and again, this may be of interest to folks who are being treated for malignancies, there's also immune globulin. So that's when they collect antibodies. So antibodies being the way the body fights off infection. They collect those from people who have gotten the vaccine, and then they pool those antibodies and give them to someone who may not be able to make an antibody response against an infection themselves. So we can do that. We use that kind of approach with many infections. We can do that for monkeypox as well. And that would really only be used in very specific circumstances for someone who has an immune problem. The average person wouldn't require that kind of medication. So then prevention, which is really the most important thing that we're doing for monkeypox. So as I showed before, there was that very steeply declining curve here in the US. And so, here in New York City. And so why do we think that's happened? I think vaccines are a big part of that. There's been a major effort by the Department of Health to vaccinate people at highest risk for monkeypox with the Gyn vaccine. So to kind of put that into perspective, because vaccine supplies are limited, right now we are focusing on the people who are most likely to catch monkeypox in the immediate future. So that's probably not going to be most people listening to this call. So would not recommend asking your primary care doctors or your oncologist to give you the monkeypox vaccine. Because we have very limited supplies right now, and we're giving it to the folks who are going to probably catch it next month, next week. Those are the folks we're focusing on right now. Hopefully, as we get more supplies, we'll move out to other people, including people who have immune deficiencies, things like that. But for right now, we're focusing on the highest risk people. And that's currently being defined as men who have sex with men, so gay and bisexual men, or transgender women who have multiple sexual partners. That's how the Department of Health is describing those high-risk people now. That may change. And just like we experienced with COVID, we learn new things. Epidemics take a new, epidemics take a new form. And so that may happen with this one as well. We'll have to see where the illness takes us. But for right now, that's the highest risk group, and that's where we're focusing our vaccination efforts on. So the vaccine has been shown to be very effective in research studies. Some research studies done to see its use against monkeypox. It's about 80%, 85% effective after someone gets 2 shots, and that second shot is a month after the first one, and the effectiveness comes in about 2 weeks after that second shot. So it takes a little bit of time for the vaccine to give you the protection it might yield, probably about 6 weeks after the first shot. But it does give protection. There's also another vaccine called Icahn 2000. We are not using that one routinely here in the US either, because it's not safe to use that in people who have immune problems, including people with HIV. And so we're not using that vaccine routinely right now. We're using the Gyn vaccine. So when people talk about a monkeypox vaccine, that's the one they're going to be talking about. But kind of the most important thing, and I think the thing for everyone to take away from this, is that there are things that we can do just in our daily lives to reduce the chance of catching monkeypox ourselves, or if God forbid someone had it, passing it on to somebody else. And so kind of all the things that we've learned in COVID also work against monkeypox. So avoiding close contact, so things like social distancing, is effective for monkeypox as well as COVID. Avoiding skin-to-skin contact with people who either may not be in your immediate circle or who may be at high risk for monkeypox or have skin lesions. So you may want to talk to people you're going to put skin-to-skin contact with to make sure that you're aware of their risk and they're aware of your risk. Avoiding contact with objects and materials that someone who has had monkeypox has used. And that's very specific, meaning, and that's specifically about soft materials, things like linen, towels, things like that. So plastics and metals don't carry monkeypox. So you can ride the subway. You're not going to catch monkeypox from riding the subway, not by touching the pole of the subway. That's not a way of transmitting monkeypox. It's things like sleeping in the same bed with someone, sharing a towel with someone, handling dirty clothes, things like that. But hard materials like plastics, metals, those do not transmit monkeypox. And then finally, good advice all around for any infectious disease is to wash your hands often. that will protect you from, if you do contact anything contaminated, that will help prevent you from from infecting yourself with it. And then finally, the CDC does have some recommendations about how to reduce risk with if you're going to be intimate, and there's a list of some very good advice there on the CDC webpage. But I do also just want to really talk about how to think about monkeypox in the kind of context of other risks. So as I mentioned before, monkeypox is not a sexually transmitted infection. It's a disease spread through intimate contact. That can take many forms. As these recommendations say, it's skin-to-skin contact. So that can include sex, but that can be hugging, that could be playing football, that can be a yoga class. So it's any sort of skin-to-skin contact. When we talked about earlier about that first case, that case was that person who first contracted monkeypox happened to be a gay man. So who do gay men often have skin-to-skin contact with or intimate contact with? Other gay men. That's why it's been in that community. There's nothing about the LGBT community that makes them more likely to have monkeypox or anything about their lives that make them more likely to have monkeypox. It's just that people are intimate with people who are similar to them, and this happens to be by bad luck. That's how this happens. But it doesn't mean it'll only be in that community, and that's why it's really important for everyone to kind of practice these basic prevention techniques, because that's the only way we're ever going to get rid of monkeypox is if we all protect ourselves and each other. And so even if you may not be personally at high risk for it, these things will protect you from both monkeypox, the flu, COVID. It works for everything. Like the basic things really are the best thing. And so just want to make sure that to be very clear about that while it may primarily affect that population, there's nothing about that population that makes them particularly at risk for it. And it could move to other groups. So we have to kind of all work together to try and keep this contained. And I want to thank everyone. I know I talk really fast, I'm sorry. And I know it's a really technical topic, but I'm happy to answer any questions or anything like that.
Thank you so much, Richard, and especially considering the fact that you are in an airport right now. I'm wondering if you could talk a little bit specifically, and actually if your slides are over and you want to take off the screen share so we can see you a little better would be great. But I'm wondering if you can talk specifically about our cancer population and what they need to know. And I guess what's unclear, at least to me, if you are immunocompromised, are you more at risk for contracting monkeypox if you have, if you're on the subway and you're next to someone, who has it, and it's kind of an unknown thing. So I'm wondering if you could speak specifically about risks for gynecologic cancer patients as well as appropriate preventive measures for this population if they should be more strict than other populations.
Absolutely. So patients with gynecologic cancers are no more at risk of monkeypox compared to people with other cancers, but people with cancer in general may be at risk because they would be part of one of those high-risk groups that if they did get monkeypox would be more likely to have severe disease. So that would be a person that if you ever did get monkeypox, we would offer you treatment for it. But monkeypox, it's not the risk of monkeypox is not really about your underlying medical conditions, it's about your social exposures. And so while you may be more likely to have illness if you're exposed to it, it's really the main question there is the exposure. Mm-hmm. And so that really depends on, everyone's life is different. It depends on what risk someone may take, and there's no life without risk. But just to say, what kind of physical interactions you're having with people, what kind of socializing you're doing, things like that may determine if you're at high risk for monkeypox or not. There is something to do if you're exposed to monkeypox. And so if you are afraid you've been exposed to monkeypox, please call your doctor immediately, because that is the situation where we would offer someone who maybe traditionally be at low risk for monkeypox, we would vaccinate that person. So if you're helping your friend move, the next day they call you and say, oh no, I got diagnosed with monkeypox, that would be don't wait and see. Call your doctor immediately and let them know, because then they can offer you an exposure vaccine.
Interesting. And in terms of vaccinations, I know you were saying that right now, vaccines are being reserved for the most high-risk population, mm-hmm. which it sounds like are men who have sex with men for the most part. And what do you anticipate the next wave of people would be? Again, just kind of thinking of something like, in COVID, would the next wave be people who have an underlying medical condition? Would the next wave be older people? Again, I know it's related to exposure and risk, but can you talk about that?
So, I mean, so just to preface, this is wild speculation. So
Yes.
I can't say for sure. But so because monkeypox is spread through intimate contact, so that'd be like close, like skin to skin contact, close proximity. The thing that we're mostly worried about is college students who are living in close proximity, who maybe socialize with many people. So we're worried about schools starting up right now. So that's the group we're really worried about. I don't think that people who have a history of cancer are going to ever be specifically at a high risk as a group. But if someone had a history of cancer and was a part of a high risk group, so if someone were taking college classes, something like that, or if someone had a history of cancer and was a man who had sex with men, that would be, they may be someone who's at risk of having a poor outcome. But I think that people who have a history of gynecologic malignancy or malignancy in general, I don't think that they will likely be a group at specific risk. But if they are ever exposed, we want to be very cautious and make sure we protect them if they ever have an exposure.
That's interesting. And, you know, again, what could, and this is your speculation, what could the potential trajectory of this look like? I mean, that was a very encouraging graph that you showed us, the numbers kind of going way down. You know, at some point, will this go away? At some point, will everyone just automatically get vaccinated? Like, you know, in general, with this type of quick, big surge in specific populations, does it sort of then jump to other populations and then it has another surge? I mean, what does sort of the path potentially look like?
So it's a little bit hard to know because there's some things about monkeypox we don't know. And there was a clue to that really way back at the very beginning of the slide. We don't know where this virus lives when it's not infecting people. So we don't know what animal, so we usually use the term a reservoir. So like, you know, where is like the source of this infection when it's not infecting people? So for some examples, like the reservoir of flu is birds. Birds carry flu and transmit it and eventually jump from birds to humans. Or the reservoir of Lyme disease is rodents. So mice catch it, fleas get it from the mice and then they bite people and people catch Lyme disease from that. We don't know where monkeypox lives. We don't know where the reservoir is. So we don't know if there's an animal compatible with that here in the US. It may require an animal only indigenous to Africa. We don't know. And so it might not be possible to be endemic here. We're not sure. So unfortunately, there are a lot of really like big unknowns that it's hard to really estimate if this will become something you have to worry about for a long time or only for a short time. But I think that those graphs are really encouraging. But it's gonna really have to wait and see what happens next. So I can't really speculate right now because there's too many questions that we don't have the answer to.
And so for anyone watching this, and again, that would be somebody who is either a cancer patient or a survivor, what would you say the main takeaways are in terms of what they really need to know about monkeypox right now for them?
The first thing I would say is you do not need to freak out. I want to reassure you that while the media and the news may be very scary, monkeypox is a well-known, well-described, and treatable illness. Most people who have gynecologic cancers will not be in a high risk group. So you will not need to worry about monkeypox in your day-to-day life, generally. But if you are ever exposed to monkeypox, there are things you can do to help either prevent or make that infection less severe. And I think the really important thing is to have quick communication with your providers. So if you are ever worried about an exposure, to please let your doctor know as soon as possible so we can do something about it. And kind of more big picture, really the best way of protecting ourselves from infectious diseases in a complicated society with lots of travel and things like that is this open communication with the people in our lives. So if you're interacting with people regularly, it'd be good to know, you know, have they traveled? Have they been feeling ill recently? Things like that. So just talking to people in your life and talking to other people and telling people if you're feeling ill, if you have anything you're concerned about, keeping those lines of communication open with people in your life so that way you can make sure that you protect yourself if you need to protect yourself.
That's really, really helpful. And do you foresee at some point that vaccination will be more widely available, even though it's not, you know, necessarily available right now to individual folks that are outside that highest risk group?
So I think that's really going to be more of a supply chain issue. So I think that if and when we have more vaccine available, it might become something that we would vaccinate people who are at high risk of having a poor outcome in places where there are rising cases of monkeypox. But that's really going to be more a question about what we can do on the pharmaceutical end to make enough vaccine. I anticipate that someday we'll get there. I just don't know how long it will be until they're able to get enough vaccine made for everybody.
And if anyone watching this did see a lesion of some sort, and you showed us that the lesions really can take a lot of different forms, that they're definitely, different, they looked different. So given that there are a lot of different options and given that it is so new, what would you suggest they do? I mean, should they wait and see? Do they take a picture and send it to their doctor? Like, how quickly should they act if they see a funky looking lesion somewhere?
So I think that particularly people with a history of cancer, being in communication with their doctors is always probably going to be a good idea. And I think I think that it would be better to take a picture and send to your doctor and say, should I be worried? Than waiting until you're very ill. But to reassure most folks that even if they did, like most cases of monkeypox are mild, and so even if they did contract monkeypox, they probably will be okay. But I think if you're worried, I would just take back a picture and send it to your doctor. And because there are some signs that we can use to figure out if this is monkeypox or not. So I think that would be the first step. If you're worried, let your doctor know. And
how, I know you showed us kind of the trajectory of the, of the disease and it's a month-ish or so. So is the person considered contagious within that 1 month period? Again, if you're going to be, have plans with somebody who has had monkeypox, at what point is it do you have the all clear?
So yes, someone is considered contagious the whole month. While we would recommend isolation at that point. Someone would only be considered no longer contagious once all their lesions have scabbed over and those scabs have fallen off and new skin has grown underneath. Up until that point, I would not recommend anyone have contact with those people, particularly some with a history of cancer.
Interesting. Great. You have a couple of questions.
Okay. Thank you for all this very important information. And I have two questions. One is, if a person was, given the smallpox vaccine years ago in childhood, that do anything to help you not get monkeypox today, if it affected in any way?
Okay. So an excellent question. So the vaccine that we're using for monkeypox is a smallpox vaccine, right? And in the past, people were routinely vaccinated against smallpox. But unfortunately, people who are vaccinated against smallpox as a child, we would not assume they have any protection against monkeypox right now. It's just been many, many years since that vaccine was administered. And if someone had been vaccinated against smallpox as a child and are now a member of a high-risk group, we would recommend they get revaccinated. So unfortunately, I don't think you'd have any extra protection. Sorry, Mark, I'm having a little trouble hearing you.
But only to get revaccinated if you feel you were exposed or you get sick yourself.
Or if you're in a high-risk group. So if right now that's considered men who have sex with men and transgendered women, that we may define a high-risk group differently in the future. But for right now, if someone had gotten the smallpox vaccine in the past, but now is part of a high-risk group, we'd recommend they get revaccinated.
Okay,
or if someone has an exposure to someone with monkeypox, then no matter what group they're in, we'd recommend they get vaccinated. Right. We could get that done for you.
Okay, that's my second question. I'm immune compromised because even though I'm past the cancer and chemo and treatment, I take a PARP inhibitor, which makes me immune compromised, and it's an ongoing thing I take. So does that mean I should get a new vaccine for the monkeypox?
So no, not a routine vaccine, because you're very unlikely to be exposed to or contract monkeypox.
Right.
But if you had a confirmed exposure, so say, you went to visit a friend's house and then on Monday they give you a call and said, I just got diagnosed with monkeypox, then we would vaccinate you. And
right, so I understand.
Yeah.
So, because you mentioned, but I don't do anything now unless, God forbid, down the road I feel I'm exposed. I don't have to do anything proactively now.
So no, we would not recommend a proactive vaccine now, but if you ever were exposed, we could give you a vaccine soon after exposure to prevent disease from happening.
And when you say call the doctor, are you talking about the oncologist, an internist, an infectious disease specialist? Who would be the best person to reach out to immediately?
I think the doctor who knows you best. and that might be your oncologist or it might be your primary care doctor, depending on who you are and your relationship with those doctors, because there is an apparatus for the doctors to get someone referred to get an urgent vaccine through the Department of Health. Oh, I'm sorry, I was going too fast. Let me slow down.
You said,
So,
right. Sorry,
so let me slow down a little bit. I'm sorry. I know I talked too fast.
I'm talking
so,
too fast too.
so we're on the same page. I'd recommend that you contact whichever doctor knows you best. So whichever doctor you can communicate with the fastest, and who knows you and your medical history the most, and can act quickly to help you. Because there is an apparatus that doctors of any type can refer a patient who's been exposed to get them vaccinated by the Department of Health. And any doctor can access that, not just an infectious disease doctor. But the question is just getting a doctor who can take those steps for you. And the best bet is to be the doctor who knows you best. So that might be your oncologist, it might be your primary care doctor.
Yes, my question is very similar to the one that was previously asked. I grew up in a time when we had to deal with chicken pox and we had to deal with smallpox. Now today we are hearing about monkeypox. How concerned should I be as a cancer survivor? Even though I would have had those vaccines when I was younger, should I be concerned now that I would contact monkeypox?
So I think you probably should not be very worried about monkeypox in your day-to-day life right now. Though unfortunately having exposure to chickenpox or smallpox in the past will not give you any protection against monkeypox. But I think because of the groups that are traveling in right now, it's very unlikely you'll be exposed to monkeypox. And I think if I had to choose anything to be worried about right now, I'd still be worried about COVID. But I think monkeypox, something to be aware of. If anyone in your life ever tells you that they caught it or you were exposed to it, really the takeaway is to call your doctor as soon as possible. But I think that my message is a message of reassurance. I think you probably don't have to worry about monkeypox very much.
Covered a lot of territory here. I'm not sure if there are any more questions before we wrap up, but this was really, really informative. And I like that you wrapped up with this is a message of reassurance, because I think especially as cancer patients and cancer survivors, there really is the concern anytime you hear about, a new, disease or a new outbreak of a disease. And I think that that's wonderful.
Mm-hmm.
Yes, thank you. I understand what you said about having an old vaccine for smallpox is no longer adequate. It's already worn off all these years. But so I had chickenpox as a child.
Mm-hmm.
So that would give me immunity, but does that still last all these years, or that also wears down?
So chickenpox immunity is lifelong. So that one is still protecting you from chickenpox. Chickenpox and monkeypox are actually in two separate families. So immunity against chickenpox doesn't give any cross protection to monkeypox. But you can be confident you're immune to chickenpox. That one lasts much longer.
Okay, sorry. I signed on late, and I'm just curious. Can you check the titers for the smallpox and that? And if you've come up that you're still immune?
So unfortunately, we don't have a routine lab test for smallpox titers because smallpox is theoretically has been eradicated in the 1980s. So it's not a test that the average doctor can send for you. And so unfortunately, we don't have an easy way of measuring that.
Okay, and as I said, I signed on late. So should I add this into my repertoire of vaccines?
So right now you would not be. So right now the vaccine is only being recommended for either men who have sex with men or transgendered women who have multiple sexual partners, because they're the folks at highest risk of catching monkeypox in the immediate future. Other folks are not recommended right now for routine vaccinations. But if someone has a confirmed exposure to monkeypox, we can vaccinate them as part of trying to protect them from becoming ill. And the way you access that is by calling your whichever doctor knows you best, and they can connect you to the Department of Health to get that done for you.
Okay, thank you. Sorry to make you repeat.
No. I'm happy to repeat the message. It's an important one. It's an important takeaway.
And I think for those who signed on late, one thing that you said, Richard, that was really interesting is that it actually cannot be transmitted through, I guess, hard, solid surfaces like plastic or metal. So it's not something you could, in theory, catch on a subway or bus or something like that, that it's actually through like linen and, soft materials. So I thought that was really interesting and definitely something I did not know.
paper and cardboard are not transmittable either. It's really porous fabric. So like towels, linen, sheets, clothes, things like that. They actually did a study where they tested all these materials with a variety of viral tests. And the only place they could get viable virus from was from fabric and linen.
Okay, that's very interesting because I would look at paper or cardboard as being porous.
So were folks able to hear me?
Yes.
Okay, yeah, so cardboard, no, will not be a likely way of transmitting. So you can be confident to be at the grocery store.
Okay, thank you. Not that I go to the grocery store at all because of COVID and being immune compromised for that. So, but thank you.
No problem at all.
Thank you so much. This was,
Rachel, I have a question.
oh, sure, I'm sorry.
How about if you were to go to like a dressing room and you were to try on a pair of jeans or something and someone tried on previously, can that be a problem?
So it's theoretically possible, but if you kind of think through what that would take, someone would have to have an active monkeypox infection, go to that store, and try on a pair of jeans. And people usually have skin lesions before they feel ill. So I think it's unlikely that an exposure that way would happen, but I can't say it's impossible. But I would think it'd be very unlikely. I mean, people with monkeypox feel pretty crummy. I don't think they're going to be out shopping.
So I think, again, to reiterate, Richard had a message of reassurance, that even though we are hearing quite a lot in the news, and for those who get kind of the news alerts and stuff, they do come through and it seems quite scary. I thought there were a few things that were really impressive. First of all, that if all the cases, that only one person has actually died. And although people feel crummy, that luckily, it is not considered a fatal disease at this point. So I thought that was really good. And also the fact that our population is generally very much not high risk for contracting unless you have a known exposure. So I thought that was really, really helpful also. So this was really it was very, very interesting. For those who joined late, it really is worth going back and watching the slides because I thought it was really interesting about kind of the history and origins and stuff like that, which I didn't know any of that. It's quite fascinating. Richard, thank you so much for taking the time to do this. Thank you for squeezing it into your travel schedule. As I mentioned, he is on his way to a conference right now, literally right now in an airport. And thank you for sharing your knowledge and passion with us. Clearly it's something you are really passionate about, spreading the word and kind of getting the message of reassurance out there. And thank you for taking the time to share it with the woman-to-woman gynecologic cancer population. So
thank you all for having me. I'm happy to be able to answer questions. So thank you all.